Hello guys, welcome back to Clinically Clear. So today let's cover the non-communicable diseases and the program with respect to it. Let's integrate the disease and the program so that it gets over quicker and it is in a more systematic way. So Npncd, National Program for Non-Communicable Diseases, okay, 2023. Before it was known as NPCDCS, that is National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease and Stroke. But now we have included all the non-communicable diseases like diabetes, hypertension, coronary artery disease, stroke, cancer, chronic kidney disease, non-alcoholic fatty liver disease, and myocardial infarction, and many more other non-communicable diseases. Okay, so these are the important ones. So you have process targets and you have outcome targets. Process targets. This program introduced something known as community-based screening, which is screening of everyone, all individuals aged above 30 years old for non-communicable diseases, because these diseases generally occur in your mid 40s, in your 50s, and in your maybe in some people in their 30s. So the screening is done right from the early age of 30 so that we can do early diagnosis and treatment. Outcome targets are, to reduce premature deaths due to non-communicable diseases by 25%, to reduce tobacco consumption by 30%. There are many more targets, but if you remember 2-3, it's more than enough. Organization is national NCD cell, state NCD cell, district NCD cell. Community, you have NCD clinic, and village level you have ASHA workers. ASHA worker does the community-based screening. In the non-communicable disease clinics, you can do early diagnosis and treatment. In the district cell, it is the administrative unit. The state cell is responsible for fund management and supervision, and the overall nationwide implementation of the program is controlled by the national NCD cell. Okay. Now, a common strategy for all diseases is the WHO 3-step approach or the multi-step approach, where basically we first do a questionnaire to evaluate the risk factor. Let's take the example of coronary artery disease. So we'll question them about their tobacco consumption, about their smoking consumption, about how much exercise they do, whether they have family history, whether they have had previous any incidents of any myocardial infarction, anything like that. Basically, we'll give a thorough detailed questionnaire to find the risk factors. Then we'll go to the physical assessment, where we'll check the BMI, height, weight, waist circumference, waist hip ratio, all that we'll check. Last, we'll go to lab analysis and blood work. We'll do the lipid profile, we'll check for serum lipoprotein and stuff like that. Okay, this is the WHO multi-step approach. Now, I'm telling you the preventive strategies that you can write for most of the non-communicable diseases, for coronary artery disease, for stroke, for obesity, for hypertension, for diabetes. For all these you can write it. So just this is a common thing. Okay. Primordial prevention is basically health education. So mass education about good lifestyle practices you'll give to school children, and in high risk families you'll give individual education. This is primordial prevention. Primary prevention, you have lifestyle intervention and dietary intervention. Lifestyle intervention, you will do weight reduction, exercise more than 150 minutes per week, vigorous exercise, reducing smoking, because how to reduce smoking? By you having legislative measures such as increasing taxes. Cigarette prices have been increasing over the years. Before it was 10 rupees, then 12 rupees, now it has become 18 to 20 rupees. So smoking is increasing the taxes on the cigarettes, putting pictorial warnings on the packets. All these are lifestyle interventions to eliminate the risk factors. Dietary intervention mainly is the DASH diet. DASH diet is dietary approach to stop hypertension, but it is applicable for heart disease. It is applicable for most of the non-communicable diseases. Reduce 20% the fat. The whole diet, less than 20% of it, if it should be fat, per 1,000 calories. It should be less than 100 milligrams of cholesterol, and most importantly, less than 5 grams of salt per day. This is in India. In WHO says less than 6 grams of salt per day, but in India less than 5 grams of salt per day. Okay. Increase fiber intake, increase fruits and vegetables intake. Fruits and vegetables only, fiber basically. And of course, alcohol consumption should be reduced or avoided. Okay. This is primordial prevention, primary prevention. This is common for both of them. Okay. Basically, primordial is health education, primary is lifestyle and dietary intervention. Risk factors for ischemic heart disease and hypertension also are common for these two diseases. You have modifiable risk factor, non-modifiable risk factor. Modifiable: smoking, the carbon monoxide can lead to atherosclerosis, and the nicotine from the cigarettes can increase BP, and it can even stimulate the myocardium, leading to increased oxygen demand. This is smoking. Alcohol more than 80 ml per day on a long run can lead to atherosclerosis and heart disease. Hypercholesterolemia, very important, more than 200 mg per dl. But in this, HDL being more than 30 is good, it is protective. LDL and VLDL. LDL is especially bad for atherosclerosis. VLDL increases when the atherosclerosis is still in its early stages. Then OCP use, obesity, hypertension, especially systolic hypertension, is responsible for ischemic heart disease. Okay, so all these are modifiable risk factors. Non-modifiable risk factors: as age increases, higher risk. Sex: males more than females before menopause, but after menopause, males and females, similar incidence. Family history and genetic predisposition, all this is non-modifiable. Understood? You can't do anything about it. Lipoprotein A, exercise, serum homocysteine level, syndrome X or metabolic syndrome, all these are some other risk factors. Okay, so this is also, you can write for ischemic heart disease, you can write for hypertension. Now let's go one by one, each disease by disease. Now, I told you primordial and primary prevention. When it comes to ischemic heart disease or coronary artery disease, secondary prevention is basically early diagnosis and treatment, right? Treatment: you will give antihypertensives if the patient has hypertension, you'll give hypolipidemic drugs, you'll give anti-angina drugs, all that you'll give. Early diagnosis, how? Through lipid profile. You will check serum cholesterol levels, you will monitor, you will check their blood pressure, because generally if they have coronary artery disease, their blood pressure will also be elevated. Then serum lipoprotein A, all these are early diagnostic screening tests for coronary artery disease. Okay. Tertiary prevention, there is something known as hubs and spokes model. Basically, tertiary prevention: person already has gotten heart attack. Okay, person already has myocardial infarction, you want to prevent them from dying. So what you have is, you have something known as hubs. Hubs are these special facilities, facility A and facility B, where you can do coronary artery bypass graft, where you can do percutaneous angioplasty, you can do these interventions, surgical intervention procedures, invasive procedures, to break the clot, or to revascularize the myocardium. Okay, but these facilities you won't have everywhere, right? So you need to have certain referral facilities. Basically, from C you will come to hub. From these other facilities are known as spokes. From C you will come to A, from D you will come to C, from C you will come to B, or directly from D you will come to A and B. A and B is the hub. So C spoke is within 30 minutes of the hub. It is close to the hub, and here you have basic critical cardiac care equipment. Okay, but D spoke is extremely far away. It is more than 30 minutes away from the hub. All you can do is, you can stabilize the patient, you can give thrombolytics, you can break the clot, and then refer them to C or refer them to the hub. Understood? So this is hubs and spokes model to tackle myocardial infarction. Understood? So A and B is where you will do bypass graft and angioplasty. C you will have within half an hour, you have basic critical cardiac care, and D is spoke is basically where you can just do stabilization and thrombolysis. Understood? This is about coronary artery disease. Then coming to hypertension. In hypertension, one very important thing is the rule of halves. Okay, so let's assume there's a total population. We can assume that 50% of the total population is hypertensive. Okay, it's actually 48%, 25% males and 23% females, but approximately we can take it as 50%. Out of this 50% hypertension, only 50% are diagnosed. Out of this 50% being diagnosed, only 50% are on treatment. Out of the 50% being treated, only 50% have blood pressure under control. Understood? So this is the rule of halves. You go on halving everything. So half of the population has hypertension, half of them have been diagnosed, half of them are on treatment, half of that have BP under control with the treatment. Understood? This is the rule of halves. Then apart from that, additional primary preventive measures, this is specific for hypertension, you will do something known as BP tracking blood pressure. That is, school going children, young children, you will monitor their BP periodically, regularly. You will keep tracking their blood pressure, you will keep monitoring their blood pressure, and you will observe something known as stay on track. What is this stay on track? There are children with relatively lower blood pressure. it has been observed that these children with relatively lower blood pressure, they tend to remain low, they tend to have they tend to remain with low blood pressure even as adults. Understood? This is stay on track, primary prevention. Secondary prevention, again, early diagnosis and treatment. A treatment for hypertension, what you'll give, lifestyle changes alone, or you'll give antihypertensive drugs. And this is important. How do you grade hypertension? Very important. Any question on hypertension, you have to put this. 120 to 129. See, this, just remember that it will never overlap, okay? But just to remember, you can remember it as 120 to 130, 130 to 140, 140 to 160, 160 to 180, and more than 180. But make sure that it don't overlap. That's all. Simple. 80 to 85, 85 to 90, 90 to 100, 100 to 110, more than 110. Normal, pre-hypertensive, grade 1, grade 2, grade 3. Understood? This is how you grade hypertension. That's all. And next, coming to obesity. Now, obesity, there are various indicators. The one we most commonly use is BMI, weight by height and meter square. Okay. Asia Pacific classification says that less than 18.5 is underweight. See, again here, instead of remembering this 0.9, just remember that none of them will overlap. And remember 18.5 to 23 is normal, 23 to 25 is overweight, 25 to 30 is obese class 1, and more than 30 is obese class 2. Remember it like that, and when you're writing it, just give that 0.1 gap between each one of them. Okay, this is Asia Pacific classification. BMI. Broca's index is a bit weird. It is just height minus 100, height in centimeter minus 100. To Broca's index, you put another minus and again height minus 150 divided by 2 in females or divided by 4 in males. This will give you Lorentz formula. Okay, even more weird. Ponderal index, even more weird. Height in centimeter divided by cube root of weight in kg. Okay, I don't even know how you're going to use this, how you're going to interpret this. This is ponderal index. Corpulence index is actual weight divided by desirable weight. No height, nothing. Actual weight divided by desirable weight. It should be less than 0.2. Normal corpulence index is less than 0.2. If it is more than 0.2, it is obesity. Skin fold thickness using Harpendon's caliper. Where all will you measure skin fold thickness? Subscapular region, suprailiac region, bicep region, and tricep region. You will add all 4 of them. Obviously, females will have more subcutaneous fat. So, more than 50 mm in females is obesity. More than 40 mm in males is obesity. Understood? This is skin fold thickness. Waist hip ratio, more than 0.85 in females, more than 1 in males. Now, waist circumference, don't assume that females have a wider pelvis, so they'll have wider waist circumference, nothing like that. Males, normally, male should have less than 90 centimeter, female should have less than 80 centimeter. Obesity is when males have more than 102 centimeter, female should have more than 88 centimeter. Okay, waist circumference. So you have BMI, weight by height, Broca's index, height minus 100, Lorentz, height minus 100 minus height minus 150 divided by 2 in females or 4 in males. Ponderal index, height divided by weight cube root, corpulence, actual weight divided by desirable weight, skin fold thickness, subscapular, suprailiac, bicep, tricep, waist hip ratio, and waist circumference. Understood? Secondary prevention, basically, you can give treatment like Orlistat, which is an appetite suppressing drug. Tertiary prevention, you can do bariatric surgery for obesity. Understood? Apart from that, everything else same as the common ones I told before. Next, coming to diabetes. Diabetes, basically you have diabetes mellitus type 1, type 2, pre-diabetics or impaired glucose tolerance, MODY, which is maturity onset diabetes of the young, gestational gestational diabetes mellitus, syndrome X, etc. Then epidemiological triad, this is common sense. This is just basic diabetes knowledge. What are the agent? Either insulin reduces either insulin deficiency or there is insulin resistance. There is pancreatic dysfunction, beta cell destruction. This is agent factors. Host factors, it is common at old age and middle age, obese individuals more than 40, equal in males and females, and family history or genetic predisposition, of course, increase risk factor. Okay. Environment, of course, sedentary lifestyle, that's why obese. Poor diet, then that's why obese. Then infections like mumps and Coxsackie can lead to beta cell destruction. Then alcohol can lead to pancreatic dysfunction because of pancreatitis, acute pancreatitis or chronic pancreatitis, whatever it is. So these are the environmental risk factors. Okay. Types of diabetes and then the epidemiological triad. Here also, secondary prevention meaning is early diagnosis and treatment. You will screen for diabetes in high risk groups. Okay. Which is the high risk group? This one. more than 40 years old, obese, family history, genetic predisposition, all this is the high risk group. Understood? Now, what are the cutoff values when you do screening test? Fasting blood sugar more than 126, diabetic. Random blood sugar more than 200, diabetic. Postprandial blood glucose, blood sugar, if you check capillary, more than 220, diabetic. If you check venous, more than 200, diabetic. HbA1c, if it's more than 6.5%. HbA1c is an indicator of long-term blood glucose control. That's all, if you remember. These are the cutoff values, okay? Treatment, what will you give? You'll either give only lifestyle modifications, that is diet and exercise, or you'll combine it with metformin, or you'll combine it with insulin. OHA is oral hypoglycemic agent. And you will prescribe the patient with self-care. Self-care, basically what it is, you'll give foot care. Then foot care, you'll tell them about foot care, about how to wear, soft microcellular rubber footwear, how to check for injuries, how to keep their foot clean, how to they have to wash their foot every day, clean the web space, everything. Okay, I'll make them recognize symptoms of hypoglycemia. That also you will tell them. And periodic checkup of blood glucose and periodic monitoring, and make sure that they are adhering to their drugs and diet. Okay, so these are the common, most important non-communicable diseases. Thank you for watching.